So my name is Alan McNeil. I'm a consultant urological surgeon in Edinburgh, and I'm here at the RSM winter meeting in Saalbach, during which I have presented the results of some research work that I've been doing over the past 18 years with the Mechanical Engineering Department at Heriot-Watt University. We have spent the 18 years looking at the relationships between the mechanical characteristics of the prostate and the histological makeup of the same prostates. The work began by looking at benign prostatic hyperplasia, but as the years have progressed, we moved over to looking at prostate cancer. We've been funded by the Engineering and Physical Sciences Research Council to undertake these studies. The prime output of this work is that we have developed a probe that can be worn on the fingertip underneath an examination glove, and that can be used to assess the posterior surface of the prostate transrectally. Our pilot or preliminary studies have involved using this device in men undergoing laparoscopic radical prostatectomy, and we have assessed the mechanical characteristics of their prostates in vivo, then ex vivo, and have correlated the findings with the whole mount histology from those same prostates. We've compared these findings with assessment by standard digital rectal examination and have been able to show that the IDRE performed with this e-finger device is much more sensitive and specific than a standard DRE. It's approaching 90% sensitive and specific for detecting prostate cancer. In addition, it is more accurate than transrectal ultrasound-guided biopsies at determining whether cancer is present in both sides of the prostate. The next phase of our work is to take this device into men who are attending for transrectal ultrasound-guided biopsies, and this work is to be funded by the Urology Foundation. So over the next 2 to 3 years, we will use the e-finger device to perform an IDRE on men immediately prior to their transrectal ultrasound-guided biopsies. We will then be able to correlate our findings with the final diagnosis and compare this with MRI findings in those men who have a multiparametric MRI and the final histology from those men who undergo radical prostatectomy as treatment for their prostate cancer. If our pilot findings are corroborated in this larger study, then one could conceive that an e-finger assessment could form part of a panel of tests undertaken in a man with a raised PSA, with the objective of stratifying them according to their risk of harbouring a significant cancer. Those at greatest risk could then undergo a multiparametric MRI and targeted biopsies at any abnormal lesions. The objective being that a biopsy would only be done to confirm a diagnosis of prostate cancer, and that we would reduce the risk of biopsying men with benign disease.